Uh, First of all, I am thankful to Dr. Ashok Sharma for giving me this opportunity. Professor Arun Jain, Professor Amit Gupta and friends. I will be speaking on how to improve outcome of cataract surgery in severe dry eye patient. Cataract surgery in patients with dry eye is a challenge. It carries high risk of ocular morbidity and variable outcome. These are some of the studies which I could find from the literature. Two of them are from our center. First two, one study from Dr. Vasavada, phacoemulsification in patients with Stevens-Johnson syndrome, and there is some studies from L.V. Prasad Eye Institute from Dr. Sangwan. This is our study which shows that phacoemulsification. This is a study in patients with dry eye, and it shows that phacoemulsification was safe and led to minimal complications in patients with age-related dry eye with or without any systemic associations. What should be done to improve the outcome of cataract surgery in patients with severe dry eye? One is pre-operative evaluation of each of the patient, pre-operative management of dry eye, then what precaution we have to take during surgery, and precaution during in the post-operative management. In the pre-operative evaluation, each of the patient, as we evaluate for dry eye, we have to do Sherber test, tear film breakup time, fluorescein staining pattern, and in the slit lamp we have to see any debris in the tear film. We have to rule out any Bobian gland disease, blepharitis, trichiasis, corneal vascularization or keratinization. As you can see here, if we do fluorescein staining, there will be in severe dry eye, there will be lot of staining, as it is shown here. If we do rose bangle staining in severe dry eye patients, there will be a lot of staining, as it is shown here. In the systemic evaluation, we have to rule out any connective tissue disorder such as rheumatoid arthritis, SLE, Wegener granulomatosis, Sjogren syndrome, Stevens-Johnson syndrome. At all times, we take the help of rheumatologist or internist for evaluation of these patients of dry eye. This is one of the patient where there is rheumatoid arthritis, there is small joint deformity. In the pre-operative management, it is best to prescribe preservative-free tear substitute such as carboxymethyl cellulose or SPMC. Many of the patients need cyclosporin. Sometime we also prescribe low potency topical steroids. In addition, we have to control the systemic disorder. This is one of the patient of very severe dry eye where topical cyclosporin was used before cataract surgery in addition to other preservative-free tear substitute, and on the right side is the picture after cataract surgery. Problem during cataract surgery in patients with dry eye are such as there will be dryness of the cornea, staining of the corneal epithelium if we instill betadine not into conjunctival sac but onto cornea, so it is better to avoid the installation of betadine into onto the cornea directly. Then we should try to avoid more application of topical anesthetic because there will be effect on the epithelium. In many of the patients where there is scleritis, we should avoid thermal cautery. During surgery, cover the cornea with methyl cellulose, irrigate with ringal lactate or BSS plus. This is one of the small video to show that before starting cataract surgery, in these patients, put hydroxypropyl methyl cellulose onto the cornea. then it is not difficult to carry out the cataract surgery in these patients. And any of the IOL, whether it is a single piece or three-piece IOL, is implanted into the capsular bag. This is another patient where there is a gross scleral thinning as a result of scleritis. It is a patient of dry eye having rheumatoid arthritis systemically. Same principle should be followed, that we cover the cornea with methyl cellulose, and or we irrigate BSS plus or ringal lactate onto cornea during surgery, but it is best to apply HPMC onto cornea during surgery. And surgery should be eventful in these patients without keeping a lot of any of the cortical material in the capsular bag because to prevent any of the post-operative inflammation. In the post-operative management, these patients need topical steroid and antibiotic, which should be kept to the minimum. As in adult, we may give 5 to 6 times, but in these patients it is better to give 3 to 4 times. And to continue with the preservative-free TS substitutes. Many of the complications which can occur in these patients are superficial punctate keratopathy, filamentary keratitis, epithelial defect, even infectious keratitis, peripheral keratolysis in patients with connective tissue disorders, suture abscess, and many of these patients having a very severe dry eye, they have much more chances of infection, post-operative infection than others. This is one of the patient where there was severe dry eye, and patient developed scleral abscess. The lower picture shows resolution, and the other picture shows complete healing with the scleral thinning. These are the pictures having these eyes had very severe dry eye and have frothy tear film. In our experience, one of the study which where we did phacoemulsification in patients with dry eye, majority of the patient they achieved good vision, almost 88% of the patient. Problem occurred, minor problem such as superficial punctate keratopathy and epithelial defect, because they were not very severe dry eye patient. They were age-related dry eye patient. Sometime even children, they can also have dry eye and cataract. This is one such child where there is corneal vascularization and there is dry eye. So all the precautions should be taken in such patients. These are some of the pictures showing epithelial defect and keratolysis. And sometime inadequate treatment can also lead to progressive infection and even endophthalmitis. So in conclusion, cataract surgery in patients with very severe dry eye has high risk of post-operative complication. It is important to diagnose, treat and plan surgical procedure to achieve optimal visual outcome in these patients. Thank you very much.